presentation, I would like to start by thanking Jack and his team from GC. It's for me an honor to be able to be working with you around the world. And of course, I would like to thank Stefano Troiani for the invitation and to also be able to collaborate with our projects. So thank you again for the invitation. Just to remind you, we will be in Paris, March 16, Milano, March 17, very special day for me because that's my birthday. and I will be in Madrid, March 18, and I will have the pleasure to chair the stage with Rafael Spina, my dear friend from Italy, and of course, Julio Garcia Baeza, also my dear friend from Spain. And again, Stefano, very many thanks for inviting me to Mallorca for this meeting with such a great number of tremendous speakers in Europe. So I can't wait. I think that the title is very exciting to me. We all have practices when we do both. We do aligners and braces, and it's going to be a great discussion of where we are right now with these treatment modalities. So actually, that's pretty interesting because how much orthodontic has changed, clinically orthodontic has changed in the last couple of decades. Since I'm graduated at 22 years ago from Penn, I mean, the average treatment time that we used to say to everybody was 24 months. Today, after 2 decades, I could say that the average is less than 18 months. So that's a great improvement in treatment time. But not only that, 2 decades ago, we were seeing people every 4 weeks. When I did my residency at UPenn, we used to see patients every 4 weeks, once a month. And that's the way that still many of my colleagues are doing it around the world. Today, we typically see people with an intervals of 8 weeks. So not only the time has been shortened, but the interval of the appointment has been lengthened, which is great for both the clinicians and the patients. Not only that, the average appointment time, everybody can agree that depending on what techniques you use, can be decreased substantially. And of course, the patient comfort, which I think is one of the most important things right now in orthodontics, has increased substantially. Today, we use less appliances than before in the mouth. Better brackets and better wires change a lot the way that we do things clinically. We have a better force movement ratio and many other things that have made our orthodontic day in a private office a lot easier for the clinicians, for the staff, and for the patients. So we are improving the patient experience, which is very important today for us, specifically in this world where we have so many companies outside bypassing orthodontics, getting direct to the patients, emphasizing how easy it is to do pretty much treatment at home with aligners, etc. They capitalize on this patient experience. We need to bring that to our clinics, to our environment, improve our patient experience, keeping always a outcome that is going to be a quality treatment. So that's going to be pretty much the main topic today. I live in Philadelphia, outside Philly, in one of the suburbs, probably 25 minutes outside Philadelphia. I have a private office, exclusively orthodontic office. It's called Devon Orthodontics. Me and my team, we do this every day, all day for the last couple of decades. And the main changes, I mean, we have done many changes over the last few decades and years, but today patient experience is tremendously important for us. We want to emphasize in every aspect of what we do that the patient had a good experience, not only in the records taken, but also in the delivery of our treatments. My practice, I would say, is a very typical practice in the US, where I see 1/3 of my patients are aligners and 2/3 are brackets and wires. And I could say that that is what I've seen it around the world for most, on average. So brackets and wires are still very important. We don't have to forget that basically we use them every day, all day. So we need to also have a good system to treat people with brackets and wires and give them the experience that they want, shorter treatment times, less appointments, and of course, quality results. So simplifying excellence in treatment mechanics. We are going to give you a brief review of some of the topics that we will cover more extensively in Europe in the upcoming months. So let me start just by showing you a typically patient that we see in my office. I see 70% kids and adolescents, and I see a 30%, 35% adults. So we cover everything. So that's a typical 10-year-old kid that comes to my office. This girl comes and with this problem, nothing really out of the world, some crowding, a little bit of a crossbite in the incisors, and just crowding. So the upper jaw was narrow. We have a specific analysis that we might have the chance to review in Europe about the transverse dimension coming from the University of Pennsylvania. That was really, really important for us. And so I start by expanding the upper jaw. And then after that was done, we went into the bracket system. So here we are starting with the CCO system. And we will talk a little bit more about the specific of the appliance if you haven't seen it before. Heat-activated Archiwres, a 014 Archiwire, and typically we go and see people every 8 weeks. So 8 weeks later, we change the wire, basically review oral hygiene, but we don't do anything else. And then 8 weeks after that, we are changing the wire in finishing the first stage of treatment that we call the leveling and aligning. And we are using here, I'll explain that later, a bioactive arch wire, heat activated. And then we go into the stainless steel arch wires to coordinate the arch, level the occlusal plane, which is basically one of the main topics that I'm going to be talking today in these 40 minutes. So once we coordinate the arch and we level the occlusal plane, we consolidate the spaces, we run some rubber bands as needed, either class 2 or class 3 or vertical rubber bands. Then we place the final arch wires to suck in the bite. And we will do some tip and tricks about finishing when we meet in Europe. And then we remove the braces, and this was a 13-month case. You can see here the final smile. So let's go and review another everyday case that we see in our office. So let's see, this is the before and the after. So let's go on this 11-year-old and 10 months kid. Now, a little bit different than the case before, because this case, actually, I treated with extractions. And this initial photograph, unfortunately, he had the teeth pulled before I was able to take the initial photograph. In the consultation, we sent him right away to remove the upper and lower 5. We can explain later why we do probably 80% of our extraction cases are the 5 and only 20% and are the 4th today. But I wanted to show you the occlusals, and also I wanted to show you the panoramic so you can believe that actually this kid had premolars. So we removed the upper and the lower 5, and then a week after the extractions, we saw him in my office. That's the cone being here. And then we start with the braces. So we put the appliances. That's again the CCO. with an 014 initial alloy arch wire heat activated. And again, typically we go over their hygiene, everything, and we see these people in 8 weeks. So they come back in 8 weeks, and the alignment was substantially better. So we were able to go to a square arch wire, a 2020 bioactive. We will explain more in detail about the wires and how important they are. And then after the 2020 bioactive, we keep it for sometimes 1 appointment or 2 appointments. We go on the stainless steel 19 by 25 arch wire that can give us, again, many of the concepts that we will be talking. It give us a torque expression, give us arch coordination, and leveling the occlusal plane. So once we have the occlusal plane completely level, which is a goal of the second stage of treatment, we start closing the spaces. In this case, we had a lot of those spaces closed in the initial stage of leveling and aligning, and we call this a passive space closure that is due to the interactivity of the wires and the brackets, also enhanced by the amount of crowding that these cases has. So you can see right now we are just ready to start closing the spaces more actively. In this case, I did it because the space was very small with power chains and short class 2 elastics just at nighttime. We close the spaces. We put the final arch wire, which is a 19 by 25 braided arch wire, and great to be able to suck in the bite in the lateral segments, and then we remove the appliances. And this case also, as you can see over here, was a 13 months case. So let me go here. That's the upper and the lower arch. And that's the case few months later, where the gums are a lot better. And that's our patient profile and smile. So we are going to be talking in Europe a lot more about some of the extraction cases, the management, how we can preserve the lip support by having the right inclination of the incisors. But I wanted to also share with you that even though today and probably in June, we will be talking a lot about the mechanics. The CCO is not just the mechanics. So we also have a lot of emphasis in diagnosis, specifically in the transverse dimension. Treatment planning is very important for us, and of course, patient management, which is another big topics to be able to have the results that we all want. So we will emphasize more the mechanics in these 40 minutes, but every case that you're seeing has all the records and the diagnosis and the treatment planning. The idea when we start with the CCO system was to bring simplicity to the table, consistency, to have a way to do things that can deliver not only efficiency treatment, efficiency into orthodontics, but also to be consistent for most of the cases, and always keeping quality as a major factor. I mean, if the cases cannot be treated with quality, then all the other factors are not very relevant. So that's not new. Many of you are hearing the CCO for the first time in Europe, but we've been working with this for a while. The idea came out when I was teaching many years ago in 2005. I put together the concepts in 2009, and the system was introduced in the US in 2012. And I put there CCO 2022 because that's basically January of 2022, 1 year ago, I had the pleasure to start working with GC, and as part of our partnership is this webinar and all the events that we will be doing together with Stefano and other colleagues in Europe and around the world. So we do have more than a decade or about a decade of experience with the system. So right now we know that it works, and we know that has changed many practices, many ways, many doctors around the world, the way that they do orthodontics. So some of the topics that we will review in June are the characteristic of the CCO appliance, custom prescription, and what really means to have an interactive appliances. This is really important to understand, because many of the movement that you will see are the reflection of this interactivity, and to understand how to take advantage of it. Leveling the occlusal plane and torque expression, very important. There is kind of a relationship between these two things. Arch coordination, dental versus skeletal considerations, very important. Passive space closure instead of anchorage preparation. Wow, we don't talk anymore about anchorage preparation in the CCO system, and so we will see why. And we will show you a lot of example of cases where we didn't have to do that, and extraction cases were managed very efficiently, as the case that you just saw. The 3 stages of treatment mechanics, that's very important, because that is the roadmap to efficiency. We have to have a system, we have to have a cookbook, even though some people don't like it, but we have to have a cookbook that we can deviate from based on the need of the patient. And we will do also some tips and tricks for finishing when we come back and have more time in June. So bonus coming from the University of Pennsylvania, where my chairman for so many years at UPenn was Robert Van Arsdell. As you probably know, Robert Van Arsdell was basically an iconic orthodontic and periodontics, and he was the one who put in the map the management of impacted teeth. So he used to lecture about that in every AAO that he was basically on more than 20 years in a row. And I will bring some of those protocols to all of you in our tour in Europe, because I think that is important to remember some of the concepts that Van Arsdell gave us about impacted teeth. So having said that, just a little few considerations about the appliance that we use. It is based on a self-ligating bracket that has an active clip, or a clip that can be active or can be passive. We call it an interactive. It's a good and strong, has memory and provide control, the clip. And that provide what we think is a very good torque expression. So you can see these pictures that we took many years ago in the lab when I was teaching at Penn, where you can see a 19 by 25 stainless steel arch wire, and see how the wire is pushed toward the slot and by the clip. And that's why the biggest wire that we use is a 19 by 25 stainless steel. So we don't feel like we have to fill the slot in many of the cases to be able to achieve a good torque expression. So that's comparison between 19 by 25 and 21 by 25. Clinically, we didn't see much different, at least with our slot size. And we kept our working arch wire as the 19 by 25 stainless steel. Now, very interesting is the relationship between leveling the occlusal plane and torque expression. So as we level the occlusal plane, we have realized that, of course, one thing is the expression of the wire and the bracket, but that has to really unravel for the inclination of the incisors, upper and lower, after you level the occlusal plane. The incisors don't see selanation or Frankfurt horizontal. They really work along the occlusal plane. That's why for us it's very important to level completely the occlusal plane, and that means also bracket placement has to be very good in order to have a good leveling of the upper and the lower arch. And we have found that the long axis of the incisors to the occlusal plane, when we level the occlusal plane on a 19x25 stainless steel with these braces, they have a very constant angle, about 57 to 60 for the upper and 70 to 65 degrees for the lower. That actually is very interesting because that actually help us to almost like foresee how the incisors will look if in our cases, even before we start the cases. Let me show you a couple of examples here. Let's see this kid that I treated years ago with a flare upper incisors. After I finished, it looks like that. And there was a time in the mechanics where you can see right here that we need to level the occlusal plane. We are here. Watch the upper arch, watch the lower arch, the curvature of the deep curvus P, and see the difference between this visit and this one right here. When we have the 19x25 arches coordinated, they level the occlusal plane, and we are just consolidating the spaces in order to be able to finish the case like that. Now, when you go to the X-ray, you will see that our templates can be almost superimposed on top of the final X-ray, almost perfectly with that inclination of the incisors. Now let's do a completely different case, like this one is a deep bite case with very retroclining incisors, not very nice teeth, kind of smaller, yellowish, but that's how it is. And that's the finish. So a very brachycephalic face. If you see the patient, we might see this kid the whole case when we come in June. But when it comes to the appointment where we level the occlusal plane, again, we went from an upper arch that we actually torque the teeth buccally, the incisors, just by changing the wire and letting the brackets to express the inclination with the wire, and in the lower jaw by also getting to a 19x25 stainless steel. Little trick, sometimes a little reverse curve to be able to level the occlusal plane. So watch the difference between this and this picture when you have all the brackets, all those FA points together in one line, so we can actually finish the case. So when you go back to the X-ray, the before and the after, you almost can put those templates very similar also. So there is a very good consistency on the inclination of the incisor to the occlusal plane, regardless of the facial pattern of the patient. So arch wires are very important. If you have a good bracket and a bad arch wire, that's a bad system. You have to have a good bracket and a good arch wire. These arch wires that we've been using for years and years, they've been some of them available since the 90s. And this article from the American Journal of Orthodontics, 1995, is showing us that at that time, these wires from Tommy, they were the best. They have the best super elasticity of all the heat activated wires. So we know that we have excellent wires. We know that new technologies like the bioactive wire, the 2020 that we use to finish the leveling and aligning and transition to the working stage, that arch wire has a differential force in the mouth. 100 grams in the front, 200 grams around the premolars, and 300 grams in the back. So that's why we can put those wires and let the wires work for 8 weeks, 10 weeks, even 12 weeks before we can change them. So wires are very important in our system, and that's why we have a sequence. So very simple. Stage 1, leveling and aligning. Stage 2, working stage. Stage 3, finishing stage. We have goals, and we have certain wires that help us to achieve those goals. We will review this extensively in June. Our goals is, as you can see there, very defined. We like correct rotation, steeping, alignment, etc. Stage number 1. Stage number 2, leveling the occlusal plane, coordinate the arches, space consolidation, and then stage number 3, the fine-tune tooth position. And we have the wires that we typically use in those different stages, and we will review this later case by case, and when we have the opportunity to do so. So simplicity doesn't mean you don't pay attention to things. I mean, simplicity, we want something simple, but we want something to be effective. And we use sound diagnosis, sound treatment planning, and of course, sound mechanics, but simple mechanics as you have seen in these cases. So let me show you some few more cases before we actually finish the webinar. So that's another patient that can be your patient this afternoon. My 12 years old girl. I chose for this one a class 2-ish, kind of with a little bit of kind of a class 2 division 1 type of case, with a little bit of lack of arc coordination. One premolar is in buccal crossbite, a little bit of a deep bite diastema, and canine in class 2 and on. So this case is a very typical case where I am here in the suburbs of Philadelphia. This girl I started with the upper arch. By the second appointment, I put the lower braces. And in our first stage, just leveling and aligning, we go through the sequence of the wires, 014, 018, 2020. And after the 2020 bioactive, the case gets aligned, the rotations corrected, the leveling gets better. I still have a very deep curve of speed, but then I go to the 19x25 stainless steel, and I start with the class 2 elastics. After the second appointment with the 19x25 stainless steel, a little bit of reverse curve, and we start basically consolidating the spaces with power chain and leveling the occlusal plane, letting those wires to work and to be able to level the occlusal plane. And the class 2 elastics, upper canines to lower second premolars, will also help. And now you can see the difference between the occlusal plane before and after. So it doesn't matter how you end up, maybe open, maybe closed, but you will end up with the same occlusal plane level. Then final arch wires, and then we take the braces off. And this particular case took us I believe 15 months. Yeah. So that's our patients after treatment. Now, what about this? A little bit different. She was class 2-ish. Now we're a little bit more like a class 3. 13 years old, pseudo class 3. Eccentric is almost end on, but you have a different arch coordination here. Lower arch is protruded, upper arch is flatter. Every time that she bites, she's pushing those incisors back. They have lack of torque. The canines are out, spaces in the lower jaw. So we need to put this case together. That's what we need. So we put the braces upper and lower, and our first stage is the same. Leveling and aligning, not very much crowding. We go quickly to a 2020 bioactive, and then we go to the 19x25. Watch the upper arch wire. First appointment with the 19x25. The case is a little bit curved, and then I start with class 3 elastics, consolidating the lower segment, and watch how the occlusal plane in the lower gets a lot more level after few visits with the 19x25. Now I have the case level, upper and lower. And now when the occlusal plane is level, we start sliding those teeth to close the spaces along the occlusal plane with coils, same coils heat activated, and then keeping the same occlusal plane and with some rubber bands to help us also at nighttime until we close the space completely and we are ready for our final arch wire with vertical elastics to be able to suck in the bite. And basically we finish the case. So this case was 17 months of treatment. That's a 2-year post-treatment. And basically that's our patient with the nice smile before and after. Now, sometimes simplicity means you need to go one step forward and take some tough decisions. But as a friend says, sometimes surgery is the simplest way to do things. So 15 years old, this kid was transferred to my office. It's been 2.5 years in treatment. They're trying to do everything they can to compensate or camouflage this vertical class 3 case. After 2.5 years in our office, we plan to change that. So I see the amount of armamentarium here. So we did an analysis and I talked to the parents and we agreed that the best road was basically do a surgery. So I did a VTO, an STO2, then we remove all the armamentarium. This kid has everything you can imagine in his mouth, even some tats. And then we just put back clear braces, CCO system. We start leveling and aligning. And in few appointments, we were able to level the upper and the lower arch independently. We consolidate the spaces. We use class 2 elastics to decompensate the case. And then he was ready for the surgery. And this case basically didn't take very long, as you can see. That was before the surgery. That's after the surgery. After 8 weeks, when we remove the wires with the hooks and we put new wires, and then I start finishing the case, final arch wire, and basically we took the braces off. So it was a surgical case, but sometimes that is the simplest way to do things. And instead of hammering this poor kid for so long, in 1 year was pretty much done. So that's why it's important to have a good diagnosis and treatment plan that it can be viable for the patients. So here's our patient, and then one more here. That's the post-treatment. We can review later the records, but you can see that the post-treatment was similar to the VTO. But sometimes, and I'm gonna finish with this one, sometimes the treatment plan called for camouflage, and this 25 years old had a class 3 and didn't want to have a surgical treatment. As you can see by the CEF, he had a really large mandible compared to the anterior cranial base, very hypoplastic maxilla. So we have to camouflage this case with orthodontics. So we start just like all the other cases, leveling and aligning until we got to the working stage with 19x25 stainless steel. And we start power chain, lower jaw, consolidate the spaces, leveling the occlusal plane, class 3 elastics until we got almost end on. We have some space remaining in the lower jaw. If we didn't have, I will do a little bit of a IPR, interproximal reduction, power chain, more elastics. And then the case started getting together in a much better way. Then we put the final arch wires, and we took the braces off. This case actually, because of the lack of crowding, was pretty quick. So the was only 14 months treatment. And that's, I think it's 1 year post-treatment. So this is just a summary, and I would like to really finish just showing you this half case, because as a bonus, I told you that I will share with you some of the strategies to deal with cases like this case, where she comes to the office looking like this, and you see a baby cannon in the upper jaw that is still there. You take an X-ray, and basically it's an impacted canine. So we knew that it was impacted. So we kind of open the space with braces to do an exposure. As you can see, the X-ray. This X-ray was just taken before the case was exposed. It was palatally. And basically, we will talk about the differences between exposing a tooth from the buccal or from the palate based on Van Arsdale protocols to be able to get the canine looking like that, where you don't see any problems, look like it was good all the time. So that's basically it for now. There's a lot of things that we wanted to cover that we will cover if we have more time, different type of cases. And I will share with you what Van Arsdale used to say, what every orthodontist should know about impacted teeth. And I can't wait. I mean, I'm happy to go back to Europe, be able to share with you in different places how we're managing different cases, from the simple to the toughest ones, and with a simple system. And then I will just to thank you very much for today's presentation. Coming soon again. See you back in Europe. So if there's any question, I will just leave the microphone to Stefano. I think I was on time here. I don't like to I never like to go over time. So I try to do this in 40 minutes, but if there's any question, please let me know, and we can try to answer that, Stefano.
Well, you were absolutely on time. I think you could get honorary Swiss citizenship. And thank you very much for the fantastic presentation. That was, as I say, an appetizer for what is coming in the 3 dates in March. Not June, March 2023, and also in Mallorca during the symposium. There are some questions that I will forward to you. One of our colleagues, Dr. Andrea Freudenberg, has got 2 questions. The first one is, why do you use the single elastic ties with self-ligation brackets?
Oh, yeah, I'm assuming he's talking about the colors.
Yes.
The elastomeric ligature. Yeah. So the answer is very simple. Is because kids just love the colors, and in the US that's a big thing. So talking about having these people happy. So what we typically do is when we start the case, specifically if there's any if there's crowding, if basically every time that we start the case and we think there will be a lot of sliding between the brackets and the wires initially, I don't place the colors. I delay that until the second appointment or the third appointment, where the sliding between the brackets and the wires is going to be very insignificant clinically. So, but yeah, I mean, when that's basically how we do it. So for most of the cases, when we start no colors, after 1 or 2 appointments, the colors goes in, and that's how kids love it. I mean, it's just unfortunately, or is one of the things that we need to deal with. Yeah, and sorry about the June. I mean, it's in March. We're coming in March. I don't know why I was thinking about June. But anyways, thank you. March.
Sure. Same doctor, Dr. Freudenberg. Why do you use many elastic chains?
Yeah. We use the elastic change to consolidate the spaces. So if there is any spaces, when I have to close a space that is very large, like 5, 6, 7 millimeters, let's say a missing tooth that you decide to close the space, I typically use coils to close the space. But for the typical little spaces in between teeth to consolidate them, I use elastomeric chain. Believe it or not, it works really well. I know that many people have over the years have talked about, no, they produce friction, too much resistance to sliding. I mean, we've been using them for years and it works really well. It closes the spaces nice. That doesn't delay treatment, and it works pretty efficiently. Some people used to put it under the wire. It's the same. So I mean, we just go for what's more simple and faster, and it's to put just on top of the wire, and it works really well. Yeah.
Yes. Dr. Curie asks you, which is the last arch that you used before surgery, the one with the hooks?
Yeah, so typically for the cases, we're trying to work them up to a 19 by 25 stainless steel arch wire. That's my working arch wire, and that's the wire that I typically use with the hooks for surgery.
Then there is a request, more than a question, that is if you can show again the slide with the Archiwres sequence.
Yeah, we can do that. No problems. Is this one here? Yep.
Yeah. So I guess that will do. And another question from an anonymous attendee, where do you place the brackets? So I guess is referring the placement on the crown.
Yeah, that's something that we will cover when I go in March to Europe, and basically is the FA point. And I don't know if you're aware, but the AEO will award Larry Andrews the Ketchum Award, which is one of the biggest awards the AEO gives every year. And finally, Larry Andrews is going to get it in Chicago this year. That's the award that the ABO gives. So why I said Larry Andrews, because as he developed the straight wire appliance, he had a huge influence in what I do. So he describes the FA point as the center of the clinical crown, and basically all the appliances, to be a true straight wire appliance, you have to have the torque built in the base of the bracket, and you have to have an ideally a kind of in the same line the FA point in the crown, the slot, and the center of the base. So in that way, every bracket will be at the FA point, and when you level the occlusal plane, the crowns will be aligned as good as possible based on the 6 key of occlusion that Larry Andrews basically developed. So it's the FA point, but we will talk about that extensively, or at least we will talk about that in March. Yep.
Next question, also for an anonymous attendee, do you cinch back the wires?
And we used to do that at the very beginning when I started 20 years ago. Right now, we don't do that. Now, let me a little kind of a parenthesis. Some of us cinch the wire back, so when the wire slides back, doesn't poke the patient, because the wires, they do slice back. But we learned back in the days that we needed to cinch the wire back to create anchorage. So the molars will upright rotate, and the cinch will keep the incisor from moving. We don't do that anymore. We found out that we don't need anchorage preparation anymore with this system, and that will require a little bit of an explanation. But the only reason why I would say cinch the wire back is just to avoid poking, kind of bothering in the gums the wire, but that's the only reason. So I personally don't do that. I cut a flash and I just put stops in the wire so the wire doesn't slide.
Yes, perfect. Next question. There was a case where you had a strong curve spin in the lower jaw. You had a working wire 1925 steel. Isn't that too strong?
The beauty of the stainless steel wire is that you can add as much or as less of curve speed as you need it. I'm gonna show you a video when we meet how I do it and how you can have control. So in some cases, I do a little bit of reverse curve, very subtle. In some cases, I do a lot more based on the pattern of the patient. Brachycephalic, very deep bite, super low angle. I'm gonna have to add a little bit more. In a very mild case of a little bit of a deep overbite, I will do just a little bit. So you can control that, and so the amount is not the same for everyone. Yeah.
And the last question is not for you, actually, is more for the organizer. So Jacques is going to answer to this one. Dr. Curie is asking if all upcoming courses are in English, including the Milano one.
In Milano, there will be Antonino Secchi on stage, and also Raffaele Spina, and Raffaele Spina will speak in Italian.
Perfect. So if there are there is one other question. Which stops do you use for the arch?
Yeah, I actually use the stops from GC. Those are independent stops. They look like a bracelet. So I grab them with the Weingart plier, and I just kind of clip them in the wire. I typically use 2 in the upper jaw and 1 in the lower jaw.
They can be found in the GC Ortho catalog.
Yes. And another question is if you cinch back the wire with the Curvos P. So when you place a reverse Curvos P, if in that case you cinch back the wire.
I don't, and I know where that question is coming from. It's coming from the fact that people are thinking about that that I will that as you level the occlusal plane, the teeth flare. So that requires a little bit of a diagnosis in the way that if you have a case where the deep bites, also the upper teeth are retroclined and the up and the lowers are retroclined, you can allow the teeth to flare a little bit. On a brachycephalic patient, the lower incisor can be, in a low angle case, can be 100 degrees without any problems. The same way on a very vertical case, it will be 85, 82 degrees, I've seen it. So the typical 90 degrees to the mandibular plane is in mostly mesocephalic cases. Now, if you have to level the occlusal plane on a case that has flare out teeth, all depend how flare out the teeth are. I mean, if it's too much, that case might require actually a different treatment modality. I mean, you might have to put extra torque on the wire to compensate for it, or sometimes you need to create more space, even IPR, or in some cases, even though we don't do many extractions in low angle cases, sometimes you have to prepare cases sometimes for a surgery. So the management of the lower incisor and the reverse curve has a lot to do with how those incisors are initially seated and the pattern of the patient.
Jack speaking. Regarding the course in Milano, I just get the information from Paolo, the organizer. All the conference will be translated in Italian. Antonino and will be translated. So that's done.
Perfect. So I guess there are no other questions, or at least nobody is writing anything else. So this is the last chance in case someone wants to have some doubts clarified. Otherwise, you have got still the fantastic opportunity to come to one of the 3 European dates. There are actually 2 more they did. Do you use specific prescription for extraction cases to control expansion or on ectopic elements?
Stefano, I typically use the same prescription for all the cases. The only teeth that I change sometimes are the canines. Sometimes I use zero torque for the canines in cases where the upper arch is not wide enough, and we couldn't expand it, and you don't want to have those canines kind of too tight with the lowers. I use the 0-degree torque. Other than that, the rest is pretty much the same prescription for all the cases.
Perfect. And one last question is for you, Jacques. Someone is asking if the meeting in Paris will be in English, or it's going to be, probably the question is going to be, is if there is going to be a translation in French.
Very good question. I don't know yet, but I can answer in a couple of days for sure. But normally it could be in English.
Okay, perfect. So thank you very much, Antonino. Fantastic presentation and very punctual and very good answers to the questions. And